Welcome, everyone. My name is Margaret Howarth Brockman. I'm a Senior Program Manager at the National Collaborating Center for Infectious Diseases, or NCCID. And welcome to our webinar today, From Sewers to Solutions, Transforming Public Health Through Wastewater Surveillance Success Stories. This webinar is co-hosted by the NCCID in partnership with the Canadian Water Network. NCCID is funded by the Public Health Agency of Canada to mobilize and translate knowledge and evidence for use in public health planning and policy. I'd like to start by acknowledging that NCCID is located at the University of Manitoba on the ancestral lands of the Anishinaabe, Anishinaabeg, Dakota Oyate, Denisolan, and Nehitwak Innuwak nations. It is also on the homeland of the Red River Métis Nation. We are on Treaty 1, and we recognize that this and other treaties have been implemented as part of a process of colonization intended to benefit some while harming others. We are committed to working with all of our partners towards reconciliation. Today's webinar aligns with Truth and Reconciliation Commission calls to actions 1, 18, 53, and 79. The calls to action urge the federal and other governments to acknowledge and address the health disparities faced by Indigenous peoples, emphasizing closing the gaps in Indigenous health by developing policies and practices that are informed by community-specific data, improvements to critical infrastructure, including water and wastewater management systems, and highlights the need for environmental stewardship and sustainable resource management led by Indigenous communities. So before we begin today, I want to mention a couple of housekeeping items. We are running this webinar through Zoom. If you have any technical problems with Zoom, please email us at nccid@umanitoba.ca. The webinar hosts, we will use the chat tab for extra communication with you all, so please keep an eye on that. However, it is not a place where you'll be able to exchange information with each other this time. The recording of this webinar will be available shortly afterwards at nccid.ca. And lastly, I just want to let you know that CWA and NCCID webinar like this is approved by the Council of Professional Experience for professional development hours for members of the Canadian Institute of Public Health Inspectors. So at NCCID, we've had the good fortune to work with Canadian Water Network for a number of years. In 2022, we formed a strategic partnership to work with public health personnel to understand wastewater-based surveillance better. With support from the Public Health Agency, our program supports the learning needs of public health practitioners working with wastewater-based surveillance. We are reaching the end of year 2 of this project, the heart of which is a strategic sharing group of local public health personnel who are working with wastewater-based surveillance. The group meets virtually every month, hearing from experts and peers on topics of interest. We also support a forum of leads from provinces and territories to discuss policy objectives and opportunities for furthering this science. Today, we're looking forward to presentations from Dr. Natalie Prystajecky, Head of Microbiology at the BC Centre for Disease Control, and Dr. Robert Delatolla, Professor at the University of Ottawa and CIHR Applied Public Health Chair in Environment, Climate Change, and One Health. They will be highlighting wastewater surveillance success stories from across Canada. Following their presentation, we'll be joined by Raisha Fernandez, a member of the Strategic Sharing Group, who will bring a local public health perspective. Raisha is an epidemiologist at Toronto Public Health, and she will be moderating the question and answer period. We invite you as participants to join in the conversation at that time by posing your questions in the Q&A tab at the bottom of your screen. You can also like and comment on other people's questions to push them up in priority and keep the conversation going. We will try to answer as many questions as possible, but we might not get to them all. So at this point, it's my great pleasure to turn this webinar over to Natalie Prystajecky, and thank you very much for joining us this afternoon.
Great, thank you for the invitation to present, and just give me a second to get my slides up. All right. Fantastic. So thank you so much for the invitation. And today I'll be talking about norovirus surveillance in wastewater along the theme of going beyond the respiratory viruses. I would first like to acknowledge with deep gratitude and respect that I am today I am located on the unceded territories of the Coast Salish people, including the Squamish, Musqueam, and Tsleil-Waututh First Nations. We have an enormous amount that we still need to do towards the goals of truth and reconciliation, but by honoring the place in which I reside and also where you all reside, we can honor the lands that we reside upon that belong to the nations on which whose unceded lands we are upon. So I thought today we would really focus on moving beyond SARS-CoV-2. Think, we have to acknowledge the importance that the pandemic had on all of our lives and on the impact of wastewater-based surveillance, but we also have to recognize the fatigue that individuals are encountering when it comes to SARS-CoV-2 information, whether it be all the different surveillance systems that are in place, messaging that was heard. And we also know that a lot of the funding that was distributed for wastewater-based surveillance was linked to SARS-CoV-2. And as we reach that fiscal cliff, some organizations and some provinces have already reached the fiscal cliff. Many other organizations are hitting that cliff at the end of this fiscal. That wastewater surveillance is often linked to SARS-CoV-2, and therefore there is a sentiment that we don't need to do it anymore. And I think we have lots of examples of why we still need to do it beyond SARS-CoV-2. And I'd like to share a few of those with you today and then go into a lot more detail about the utility of wastewater-based surveillance for norovirus specifically. So when we first, when in BC, when we initiated wastewater surveillance, it was done in a research lab under my direction, but it did take some time to then transition it from the research lab to the routine public health laboratory. And this was happening in the face of a impending triple-demic, the idea that SARS-CoV-2 would co-circulate with influenza as well as RSV. And the ask of us was not only to expand our program, but to also be certain that we could detect influenza A and B, RSV, in addition to SARS-CoV-2. And we were certainly able to deliver on that task. Our wastewater-based surveillance dashboard has a summary of all of the different data that is demonstrated here, plus the ability to zoom in and actually see that, yes, we are still experiencing a lot of influenza A. We are starting to see a decreased trend in RSV, and influenza B is on the rise. And so this has been really, really important as we transition beyond SARS-CoV-2. Likewise, we've seen the value that Mpox surveillance in wastewater has had. A new virus to us here in North America over the last few years, and new surveillance systems having to be developed from scratch. And it's not like influenza where there were already surveillance systems already in place for that virus. Mpox needed brand new surveillance systems to be implemented in terms of data collection. And wastewater has demonstrated to be, in some jurisdictions, extremely useful to either predict or confirm that circulation or transmission of this virus is occurring in the community. And in our hands, we do see that we generally get the wastewater data on Thursdays, and then we get a summary of clinical cases on Tuesdays, and they always correlate. It doesn't take many cases here. In our hands, we've seen that, as few as 1 or 2 cases can result in detection in wastewater, albeit at the limit of detection, but it's extremely valuable. And you can imagine in this scenario where you start to see perhaps signal in wastewater in the absence of clinical cases, then that would result in a change in public health messaging about vaccination and testing. And so this has been very valuable data in our hands. And I want to emphasize that this is BC data that is generated by the Public Health Agency of Canada NML site. And lastly, I wanted to highlight sort of the new kid on the block, the H5 highly pathogenic avian influenza. This has been circulating. We are in the midst of a very large ongoing outbreak of avian influenza that has been ongoing since 2022. The difference is that we've seen substantial and sustained transmission from from wild birds or poultry sources to mammals, so specifically transmission to cattle. We've also seen a number of events where there's transmission to humans as well. And of course, this is very concerning as it demonstrates there could be adaptation. So having tools that can actually detect H5 in different species is very important. Now, wastewater, the challenge with wastewater is that doesn't necessarily mean that an H5 signal is from human or from animal, but to have a surveillance system that says, yes, something is happening and something is different than before is really important. And data from Ali Boehm's group has shown that, with the spillover into cattle, they actually went back to historical samples and demonstrated that had they been testing for H5, they would have been able to see that something was different prior to the transmission actually occurring to cattle. So it really emphasizes the value of this H5 data. And we've been doing that testing ourselves here in BC and have shown very little H5 in wastewater, and shows the value of actually having negative results. Having negative results is a good thing. So next, I want to share with you our journey with norovirus testing in wastewater. And I will share that, I am by training an environmental microbiologist, and norovirus is in my area of the lab. I oversee norovirus testing for the province. Very excited to be able to present to you about norovirus in wastewater. And I'll say it makes a lot of sense to be testing for enteric pathogens in wastewater. When we first detected SARS-CoV-2 in wastewater, my initial thought was, yes, this is occurring because there's an extremely high viral load. It's a novel pathogen. It might be replicating in other body tissues, and that may reflect this high value. We see now that that's not necessarily the case. But when we were asked to test for influenza A, I wasn't convinced it would work. Why would you test for a respiratory virus in wastewater? But what we've demonstrated, in fact, yes, you can detect all sorts of things in wastewater, and particularly respiratory pathogens work quite well. But norovirus works even better because it is a gastrointestinal pathogen. It is shed in feces, and it is abundant in wastewater. Norovirus is having its popularity right now. These are just three latest news stories. Norovirus has sort of these epidemic waves, and we have bad years and good years. And in the bad years, it typically occurs because there are new strains emerging. So norovirus, just like other viruses, there is selection for certain strains. And eventually, when there is enough immunity in the population, a new strain will emerge and become dominant. And we also know there's waning immunity in the population. So we do see usually a couple of years, 2 to 3 years of sort of ongoing activity, and then one surge year. So every 2 to 3 or 4 years, we see a surge year, and that is what we're in right now. We see, we see people calling it a quademic because we have all the respiratory viruses circulating along with norovirus. In the UK, we're reports that possible cases of norovirus at the highest level ever, and we see that a newer strain, G217, is what is responsible for the surge in cases. So just some basics about norovirus. It is an RNA virus, and it's extremely contagious. One of the key things is that it is only transmitted human to human. There is no zoonotic source. So if you have norovirus, you have been exposed to a human source of feces that contain norovirus. It has a very short incubation period, but it also doesn't last very long. The data from the US is that there's about 19 to 21 million cases annually, with over 100,000 hospitalizations. We do not have data like that in Canada, and the last time there has been any estimates of norovirus activity was back in 2015 by colleagues at Public Health Agency of Canada. And the reason we don't have recent disease estimates is it's very difficult to ascertain for norovirus since it's not a reportable illness. If someone is diagnosed with norovirus, it does not need it to be reported to local health authorities. Why there is this, so there's this surveillance gap just because it is such a dominant infection, and generally it is self-limiting. We have in BC, outbreaks are reportable, so 2 or more cases linked in space and time, but individual cases are not reportable. We also have the challenge that testing is decentralized even for outbreaks. So historically, we did all the outbreaks, but as more and more gastrointestinal virus testing was made available in the hospital settings, some hospitals are testing on behalf of public health and those health authorities. Even if outbreak data is generated and is reported, there isn't a requirement to centrally report those outbreaks as well. And so we just don't have a good sense of what is happening in the province in terms of the number of outbreaks. The other challenge is that outbreaks can be declared and managed without testing. And there's something called the Kaplan criteria, which describes the clinical picture that can be used to attribute an outbreak to norovirus without any clinical testing. One of the other challenging issues is that it can be difficult to compel patients to produce a stool specimen. We send out lots and lots of stool collection kits. We get notified of many outbreaks, and often no stool sample comes our way because it is difficult to collect a diarrheal stool sample. And lastly, in BC, our diarrheal guidelines actually advise against testing for norovirus unless you are in an outbreak or clinically vulnerable, because it is self-limiting. And it would overwhelm the system to test every norovirus case. So wastewater surveillance can address some of these gaps. I will also add that our journey with wastewater didn't necessarily start with SARS-CoV-2. We actually had started doing work with Metro Vancouver in 2018 to understand the viral loads of a number of different gastrointestinal viruses in wastewater. We had done testing for adeno, noro, rotavirus, as well as astrovirus. And we were looking at the loads in the influent as well as the effluent to understand from the influent perspective, the public health surveillance aspects of wastewater, and in the effluent, the impact on the receiving waters, as well as the viral load reduction. So how much virus was reduced during the various treatment processes. And so as we moved on to, in 2020, when we leveraged those enteric methods to SARS-CoV-2, we were well prepared to get up and, off the ground and running to be able to use similar methods that we were using for norovirus as we move forward to SARS, or for norovirus and the other enteric viruses, as we move forward to SARS-CoV-2. Now, of course, one of the things that is most important when you're doing any lab method is to ensure that you have adequate control. So we have to have positive and negative extraction controls, PCR controls, inhibition controls, as well as process and sample quality controls, such as PMMOV. One thing I would like to just bring your attention to is the inhibition control. At the time, we could not multiplex all the different targets together, and we actually decided just to keep our inhibition control separate. And our inhibition control is actually contained within our norovirus assay. And so we had, instead of trying to revalidate the assay or pull out those primers and probes from the assay, we thought, you know what? It's not costing us a lot more money just to keep the norovirus G1 and G2 targets in there. And we might as well just continue with this testing so that we can have the historical data to link back to this project that we had already started. And this was used as a control as well, because norovirus is always present in wastewater. And so without really thinking about it, we had this bonus data. We didn't realize how valuable that data would be in present day. So to give you some examples of how we are using this data is we're looking to understand the local as well as provincial trends. What you can see is the seasonality at this one wastewater plant in one of our health authorities. And we can see that, over the same sampling period at a different site, they actually just don't have the same cyclical nature. And we're trying to understand what the difference is. And there are some sites that actually just have pretty low norovirus activity year round, compared to some sites where it's quite elevated. And we're trying to understand what this means in terms of the provincial picture and how this corroborates with other data sources. We are also using this specifically to look at outbreaks and the impact of strain replacement. So in terms of the outbreaks, we've had two significant oyster outbreaks in 2023, as well as in late 2024 into 2025. It was very important during those outbreak investigations to understand what the levels were in wastewater in the various areas to understand potential impact on the community, and also to understand the extent to which there was community transmission. And this was very important in the decision making, as well as just simply understanding the picture of norovirus, since the other sources of data are just so weak when it comes to norovirus surveillance. We have no other system in the province that can give us a provincial look at what is occurring. So with this data, we have currently we have sites in every health authority in the province, whereas our outbreak data is limited to 2 of the health authorities where BC CDC, where my lab actually does the testing right now. We've also been doing it in the context of understanding strain replacement and whether or not we expect to see ongoing increasing transmission, whether things are leveling off. So this has been a very important question as we communicate to the health authorities and other decision makers around what is going on with norovirus in the province in the context of strain replacement. We also know that this is going to be very important as we start to understand as we start to understand what is happening with the norovirus specifically in our shellfish industry. We are starting to look at a number of different parameters to actually start modeling when we expect outbreaks to occur, because we don't see oyster outbreaks every single year, but we know that the contamination is always there. So we're trying to understand, the impacts of a number of different variables that can influence norovirus outbreaks, including rainfall, sunlight, sea surface temperature, and downwelling. And now we have the opportunity to also incorporate the wastewater data into the models to understand outbreak risk, as well as inform preventative action. So what's next? We have a plan, and we've started some of this work to fully validate this wastewater norovirus data against clinical, and we did have the intention of posting this data online. The challenge is right now we're pending funding confirmation, as the state of our program as of April 1st is still unknown. What we do intend to do is to use the various sources of data, all of which are not complete, but we're looking to use a number of different sources of data to start to look at the wastewater data against these clinical indicators. So we do have norovirus confirmed outbreaks from a number of sites here in BC. We also have the number of times we've just been informed that there's been a GI outbreak and they've requested testing, even if they haven't submitted samples. We can go look at it against the billing codes, our medical services plan billing codes. And then we do have the opportunity, in the province, they did introduce an infectious diarrheal panel. If you have a norovirus result from that panel on an outpatient, you do not need to report it, or even an inpatient, you do not need to report it, but we certainly can ask for access to that data for the purpose of validation. I will share that all this work is not necessarily perfect. So this is an example. We've been looking at the ICD codes, and we did look at a range of different codes, not only those related to 8.6, which is against a virus, but we have, the wide range of ICD-9 codes. You can see, the billing codes are pretty stable with in this instance, a spike in the spring months, but does not necessarily reflect the trend that we were seeing in wastewater. So of course, we need to refine some of those analyses in more detail. So in terms of this work, there is some limitations. We have that limited resolution. A lot of this data does not come at the postal code level, so we can maybe attribute it to a health authority, but not necessarily to a community. We know the data sources are extremely incomplete, and all these data sources are passive surveillance, and only the cases that are reported. So, in terms of a summary, it is really, really important that we have exemplars beyond SARS-CoV-2 and respiratory viruses to demonstrate the utility of wastewater-based surveillance. In this scenario here that I presented, norovirus is an extremely good example because it is an example where there are not traditional surveillance methods. We know that we don't have a good sense of how much norovirus is occurring in the province, and this certainly can add an extremely useful piece of data when we are looking at that. So we have demonstrated that the data that has been generated in BC has been invaluable for public health, specifically during oyster outbreaks and periods of increased norovirus transmission. And with that, thank you very much. I believe we're saving questions until after the second presentation.
Thanks very much, Natalie. A story we hadn't heard much yet, norovirus and the opportunities there to fill the gap, especially on a non-reportable infection. So thanks for that. I'll now turn it over to Rob Delatolla to give his presentation. All set,
Thank you.
Rob?
All set. Thanks so much. I'll just
Thank
get
you.
my screen set up here. Can you guys see that?
Yes, we can.
Wonderful, wonderful. Okay, so thanks so much, and great. So thank you so much to Margaret, to NCCID, CWM, for the opportunity to speak today. And it's always great to speak when Natalie is also speaking. So I really appreciate that. And today I'll be talking about wastewater monitoring successes and maybe picking up a little bit on what Natalie spoke to as well. Before I begin, I would quickly like to make a lot of acknowledgement. So I'm in the city of Ottawa. I'm at the University of Ottawa. At University of Ottawa, we study, we work, and we research on unceded Anishinaabe and Algonquin territory. So a lot about the wastewater, wastewater monitoring story that we've heard, and Natalie touched on this, was really around COVID. So there is some agreement. If there's not agreement, there's maybe progress towards consensus, I would say, on understanding wastewater monitoring within the realm of what it could do for a pandemic, during a pandemic, like COVID, being an early indicator of all those COVID waves, being an economic means to monitor wastewater when clinical testing was no longer economically feasible. Those kind of examples I think people have heard. I'm not sure, as with Natalie talking about Noro, I'm not sure some of the other pieces have been as widely spread and as widely disseminated. And so I would like to talk to you today about wastewater monitoring for healthcare planning, for health equity, and for One Health. So with that, I wanted to share some successes, some things we learned with respect to what can wastewater monitoring, the promise, the potential with respect to healthcare planning. So this is a slide that shows the process of wastewater monitoring, and the top portion of the slide, everything from shedding to sample collection to analysis to communication, all very important aspects of wastewater monitoring. The bottom part of the slide shows you our work protocol, our process within our laboratory. So when you look at the slide, you can see there's some green arrows. Those green arrows are automated processes. And that's very rare for somebody like me who comes from a research background, from a university, being a researcher, to have automated processes really involved in a research laboratory. But we did that because we listened really closely early on in the pandemic when we started to do wastewater monitoring for COVID, to our public health partners, to our clinical partners, to our community-based organization partners, to our Indigenous health authority partners. And we heard two things really loud and clear: timely data, reliable data. So we actually automated our process within our lab so we have a turnaround time of 8 hours so that we could get data to people within a time when it was usable. And reliable data, Natalie talked on this, the need for QA/QC. So we developed a qPCR analyzer with quality assurance, quality control. How do you remove the confounding effects of rainwater when you're in sewers and it all mixed in our old cities in Canada? How about scouring effects when you bring up old material mixes with the new material? You just want to analyze the new material for disease incidence. How do you differentiate? All of those things took a lot of scientific effort early on for us to get to the point of producing reliable data. And finally, one aspect I think that's going to be kind of a through line through everything in terms of the examples I'll show you today is timely data, reliable data, but also open communication, open data, giving the data to the public so that people can see the data, and really that effect on everything from disinformation to misinformation. Okay. So first example I wanted to share with you is wastewater actioning for healthcare planning, is the integration that Ottawa Public Health did. So this is really Ottawa Public Health's success story. And Ottawa Public Health implemented in 2023 a respiratory transmission risk assessment tool. In that tool, they were looking at, very similar to what Natalie was talking about, they were worried about like tridemics, quadremics. They were worried about respiratory syncytial virus, flu, COVID, all at the same time, and those effects on our health structures, on our children's hospitals, on our hospitals, on all of those structures and that infrastructure within our community and healthcare planning. So what you see on the screen is what Ottawa Public Health did. They took 4 metrics, 3 conventional metrics that you see on the screen: outbreaks, hospitalization, percent positivities. And then they had a 4th metric, which was wastewater monitoring. They actually weighted wastewater monitoring at 40% of the total weight of those combined metrics. because they characterize wastewater monitoring as the lead indicator, with the other three traditional metrics being the lagging indicator. And a lot of that had to do with us being able to provide them with a turnaround time of 8 hours, giving them data the next day on what is happening in terms of incidents in the city. So what did they do with these metrics? Well, or with this respiratory transmission risk assessment tool? What they did is they basically characterized two different outcomes. One is they tried to predict periods of time of high activity. And how they determined high activity was they weighted, like you see on the left hand of the screen, the four metrics. And when that weighted total would be increasing in the city of Ottawa, then they would designate that a period of high activity. Then they actually were looking for periods of high risk. High risk was designated when 3 out of those 4 metrics, or more than 3 out of 4, were above a low level threshold. So periods of high activity, periods of high risk. What did they do with that data for the last 2 years? So Ottawa Public Health took that wastewater monitoring integrated data set within their respiratory transmission risk assessment tool, and they characterized those 2 periods, high activity, high risk. And when they had 2 or more weeks, they had long extended periods when they had high activity and high risk, they sent out communications. And they let the healthcare institutions, the healthcare affiliations, the healthcare hospitals within our city know. And what you saw in 2023 is September 2023, the hospitals in Ottawa reinstated masking protection at that time at the notification of Ottawa Public Health, letting them know it was a period of high activity and high risk and an extended period for over 2 weeks. So that's really one of the success stories that I don't know is really that well communicated out there about how wastewater could be directly integrated and directly actioned within for healthcare planning. A second success story is the respiratory syncytial virus story that happened within Ontario. We started to test RSV within the wastewater in the summer of 2022, right before the 2022-2023 respiratory disease season, where we had that tridemic, at least in Ontario, throughout Canada, actually, where hospitals were really hit hard by flu, RSV, and COVID all at the same time at high levels. In 2022-2023, we tested 2 areas for RSV wastewater, Ottawa and Hamilton. In the 2023-2024 season, we expanded that testing to 12 different locations across the province. Those locations were chosen for geospatial representation and social economical representation across Ontario. And those were results were directly communicated to the Ministry of Health Respiratory Syncytial Virus Advisory Group. And this is what happened. So during the 2022-2023 season, we noticed that we were able to identify the start, and this is the critical point for RSV. The key to surveillance, the key to monitoring was to identify the start of the season. Why is that? Because the RSV is associated with prophylactic administration, a monoclonal antibody administration that prevents severe RSV disease within at-risk infants. So the province designates a start date of the RSV season. That start date is associated with the administration of prophylactic across the entire province. Our study of RSV in wastewater showed that we saw RSV season in Ottawa start 36 days before the start date for RSV season within Ontario, before they started to administer prophylaxis. In Hamilton, 12 days before the start date. When we now look at the 2023-2024 season, where we monitor 12 different locations, you could see the schematic on the right, the graph on the right, is the percentage of the population that wastewater surveillance identified where RSV season has started prior to that provincial start date. So you could 86% of the population of Ontario that we were monitoring showed that wastewater surveillance showed that we were able to identify the start date of 86% of the population we're monitoring prior to the official RSV start date within the province. We saw that Ottawa and Windsor border communities started RSV season earlier, and we saw it transition basically from the east to the south back up towards the north. And there was a discrepancy between Ottawa and Sault Ste. Marie of about 3 months before the start date happened within the province of Ontario. But what does this all mean in terms of an application for healthcare? How does this impact our healthcare planning within the province? Well, in order to understand that, we did a cost-consequence model. That cost-consequence model was designed so that we compared conventional healthcare planning, where you have a single start date for the entire province, compared to if you would have used wastewater surveillance to identify the start date within the various 12 communities across the province. And we showed that we were able to reduce hospitalizations of infants, reduce medically attended visits, reduce morbidity of infants. And when you put numbers to those reductions, this is what we saw. We showed that if you would have used wastewater surveillance to monitor RSV within the province of Ontario, we would have prevented 250 infants from going to being hospitalized for RSV. Secondly, we would have prevented 950, there would have been 950 fewer medically attended infant RSV visits in that respiratory season within Ontario. And if you take the cost of how much it costs to monitor, to do wastewater monitoring for RSV in the province, and you associate that with and you balance that out with the savings from those 250 the infants going to hospital and the about 1,000 of them being medically attended to outside of the hospital, it would have saved the province about $3.5 million that year. So this is an example of how wastewater monitoring is really not only about pandemic preparedness, but it really could be impactful for Canada at the provincial level and at the healthcare planning level. But I think there's more examples than just healthcare planning. Health equity, I believe, is a really important aspect of where wastewater monitoring could be positioned and how it could be leveraged. And I think it's, the fact that wastewater monitoring is non-invasive, the fact that it's anonymous, and the fact that it's not really associated with this unfortunate medical surveillance history that we have in this country. A first example of wastewater monitoring potentially being impactful for health equity is the Mpox narrative and the Mpox story of what happened. So during the 2022 Clade 2 outbreak of Mpox within Canada, we noticed that we were able to detect Mpox within the city of Ottawa about 11 days before Ottawa Public Health was aware of Mpox being present within the city. And that 11 days, because of the stigmatization and testing hesitancy with diseases such as Mpox for specific priority populations, that 11 days gives public health, gives our community the ability to communicate, to send out notifications about vaccinations, notifications about protection, notifications to inform the community of that threat being present within the community at that time. Another position where wastewater monitoring is we think really important, and where we've seen a lot of successes is within First Nation and Northern Indigenous communities. And here you're seeing that's the wastewater being emptied from a sewer truck that has collected wastewater from homes in the Nunavik region, in Kuujjuaq, within Nunavik. And you see there, Pat from my lab is teaching the drivers of these sewage collection trucks how to connect this guy over here, this sampling device, and how to sample from that wastewater to test for diseases such as tuberculosis, where within Indigenous communities, you have incidence rates of 400 times greater than the mean average across the rest of the country. We also have seen successes in First Nations across Canada in terms of wastewater monitoring, including successes of where early in the pandemic, we were able to detect COVID within First Nations prior to them knowing that COVID has entered their communities. And the last sector, or the last application of wastewater monitoring that I think is really important is one that Natalie talked about in her presentation, and is one of the projects that I'm working on actually with Natalie and her group, and that is for wastewater monitoring for One Health perspectives, and particularly for highly pathogenic avian influenza. So we have a lot of initiatives going across the country monitoring avian flu right now. And avian flu is a serious health threat, and we hear that as the landscape of avian flu is changing every day. And we have done, if you look at what ECCC, Environment Climate Change Canada is doing, CFIA. There is a tremendous amount of work across this country being done in terms of collecting and analyzing and reporting environmental samples, wetland samples, sediment samples for avian flu across the country. There's also a great amount of initiative being done on wild birds, testing of wild birds, dead birds, eggs, all across the country. So animal testing, environment testing that we, CFIA, ECCC, OMAFA in Ontario, working together, coming together and doing this testing across the country. The piece that's missing to close that One Health loop is human testing. And, in the US, Natalie mentioned Ali Bain, her group with Wastewater Scan. They're doing amazing work testing avian influenza. The US, actually, their national program is actually testing avian influenza across the United States. We in Canada are positioned, I think, even in a better position than the US, than other European countries. We have wastewater infrastructure, we have wastewater setups within this country that allows us to isolate wastewater waste from agricultural waste, even at a better level and preferentially compared to places like the US and Europe. So we're really well positioned in a lot of our provinces to close that loop, to use wastewater monitoring to test as an anonymous, non-invasive tool to go within communities who are at risk, communities with workers at poultry farms, cattle farms who are at risk of potentially spillover to humans, for us to do that testing within those communities. And that's work we're doing. Natalie mentioned that work. And people are starting to do that work across the country. One of the projects we are on, Natalie's actually on it, BCCDC, so is ENSPQ in Quebec. And we're starting to implement this model and this perspective. And I think that's a third and final application of wastewater monitoring, potential success and promise that I wanted to share with you today. And I think I used up all of my time. And as always, these are the people who generate the data and generate the information that I had the privilege to share with you today. Thanks so much.
Okay, I'm going to take over. So thank you, Rob, and thank you so much, Natalie, for presenting. I just have a few questions for you both, and some of them are in the chat, and please keep sending questions as time goes by. The first question, just because, Rob, you were just presenting, it's on the top of my mind. When you were doing your RSV prophylaxis talk, did you get any buy-in from the province, public health units, or clinical care providers to actually start the RSV prophylaxis vaccine earlier, or did you get some pushback? And is there any talks about how they will potentially use wastewater to start RSV prophylaxis earlier each respiratory season?
Yeah, thanks so much for the question. So we had the second season, 2023-2024, we had 12 different locations. We had clinicians at each of the locations from the children's hospitals involved in the project. We had the public health unit that was responsible for that jurisdiction involved in the project. And then we did the wastewater monitoring ourselves. But it was really led at the level of the Ministry of Health, that project, by the RSV advisory group. So they were getting data from the clinical data that they always got, but they were getting our data and the RSV data at the same time. So the buy-in seemed really promising. As we were presenting them that data, the entire provincial program was closed. So that sort of took over, and that's what happened. And so since then, that's where we're at. That's the landscape of where we're at. But no, there was no, every year that group, the Ministry of Health, RSV advisory groups, selects the date in which to administer prophylaxis. So the date when we were giving them data, I won't say it influenced them. They would have to answer that question. But I know that they started the date that year an entire month or more earlier than it was the previous year where we weren't giving them data. But other than that, I can say that, yeah, that's where it landed. It landed with the program unfortunately closing, and us still saying, if anybody wants to listen in Ontario, we are very happy to repeat the message that we think it could still be cost effective to do this. Yeah, thanks.
Thanks. So Natalie, a question about you and your norovirus surveillance is, when you were started to give public health the norovirus data, Do you know if they took any public health actions from that? Like, are they still interested in receiving the data to this date? And is there anything that they actually actioned on?
Yeah, so I think we have seen the request for the norovirus data specifically in the context of the oyster outbreaks. So initially we weren't giving it to them on a routine basis. And so we were just sort of in our OYCCs for norovirus, or sorry, the outbreak coordinating calls for norovirus. We were specifically asked about whether we had data available, and it was specifically requested. We were like, oh, we do have it. It's our bonus data. We haven't really validated it, but here you go. And they were just absolutely fascinated and almost ecstatic to receive the data, simply because the other data sources are just so poor. And so we do send it to the health authorities on a monthly basis. And we, continue to get questions about, what does this mean? And, I think that there's a lot of buy-in specifically for norovirus, just given the gaps there is everywhere else. And, we are getting many media questions about norovirus, and we are certainly, we're able, to say, we have this information on outbreaks, but it is very incomplete. But we do have this information on wastewater, which is more complete.
Awesome. I know you guys are looking at evaluating your norovirus wastewater data against your clinical, but I think another part that also might be helpful is figuring out utility for public health and getting some success stories out of that. Other than just having a data for situational awareness, is there actually anything that they did to action on that?
Well, no, I'm not aware of any data that they've actually actioned on that. Yeah.
Yeah. Okay, another question that we had was, I guess this question can be taken by either of you, is can you speak to the ability of wastewater-based surveillance to predict the number of infected individuals in the populations? And are there any kind of measurement errors associated with wastewater-based surveillance?
Do you want to take that one, Rob?
Sure, I could start and maybe you can add to it, Natalie. So I would say it's been a changing perspective. So there's a lot of data that I think early on that was maybe the goal, or one of the goals that we thought we should be trying to do, is how to translate this information to cases. And there's been a number of papers published on what we call like WC ratio, wastewater to clinical case ratio, wastewater hospitalization, WH ratios. Those have been done. Eric Alm from MIT did one of the early papers. We put out 2 papers on that early on as well. But then I think slowly what we're starting to realize is, the value of wastewater surveillance maybe isn't necessarily getting back to number of cases. It's anonymized, which is really a good thing, I think. And what we've seen is I don't think we ended up seeing as much confounding effects by shedding changes. We were really worried early on that there's going to be shedding changes within different viral or different variants of COVID, for example, shedding changes year to year from flu and RSV. And I think that those sort of worries have sort of subsided, where we're kind of seeing consistency across the board. So yeah, I don't think we are there to change it to case counts. But I think it always depends on the question. Like for RSV, for example, it was really a question of when does it start? And you don't need cases to know when it starts. You could just say, this is our criteria for when this starts, or detection. Or anyways, I'll let Natalie chime in with a better answer than that. So thanks.
Yeah, I think, I think that the data on population on shedding isn't there for all the different organisms we work for. I think we had some of that early data from SARS-CoV-2. There weren't many studies where people continue to collect, fecal samples from patients and to look at the shedding. And, with, some of the gastrointestinal viruses, yeah, there's some good shedding data, but for many pathogens, there aren't. And I think that the idea that you need to back calculate to the number of cases, as Rob says, hasn't been a priority for public health. What is a priority is, as Rob mentions, beginning and end of season. So for us, that is really important, being able to call the beginning and end of respiratory season to make decisions around masking in hospitals. And that uses that data, and it doesn't matter how many people, it just it matters, where we are in the season. Likewise, I think that the wastewater data, it's often about the direction. Are we increasing? Are we stable? Are we decreasing? Are we the highest that we've ever been? those those sort of more qualitative pieces of information are just as valuable as actual quantities. Where you get the quantities, might be, quantities of patients infected might be that you want to incorporate that into a model. But what you can also incorporate into the model is actually just the viral load. So, as Rob said before, we're not there yet. And I think that we moved away from the beginning of the pandemic, where people were obsessed with saying how many cases are actually there, to people understanding the way wastewater functions, which is, in all that trend analysis.
Okay, awesome. So I have two methods questions for you. So I'll start with Natalie first. Natalie, can you explain how you normalized your COVID, influenza, RSV, or norovirus signals? And were there any issues with interpreting the viral levels? So how did you interpret the high, medium, low?
Yeah, so we did a lot of work around normalization. I think normalization was like the hot topic for late 2020 into 2021. I feel like we spent many a teleconference discussing this. And so for the most part, we normalized to load and population. We do have pepper model, mild model virus data as well. And we struggled really with that normalization. And we also saw that, in different parts of Canada, for example, there was, that the actual quantities of PMMOV were different. So, different people use PMMOV in different ways. But we did find, when we didn't have load, we would normalize by PMMOV. And, even for the norovirus data and the respiratory virus data, it kind of behaved differently. And you can imagine that, they shed very differently. And so they probably survive in the environment very differently. So it's important for each virus that you check out the normalization. But for us, when possible, we use load and population.
Okay, so my next method question is actually for you, Rob. So when you were talking about the cost analysis, I assume for your RSV figures, when you were talking about reduction in hospitalizations and non-hospitalized cases, how did you go into developing those numbers? And did you take into consideration like level of compliance with prophylaxis or human behavior change when you came up with those numbers?
Yeah, so it was just a cost benefit analysis at that point. We're just completed a cost utility analysis, which I just got the email during this thing that it's been accepted for publication. So that will be a little bit more in depth. It's basically the same analysis, but just including quality of life and lifespan. For cost benefit analysis was really quite simple. It was really balancing the cost of implementing wastewater surveillance for RSV across the province with a geospatial and socioeconomical kind of balance or equal representation, or as much of representation we could get, and then really just understanding that the earlier, because we had the data from all the clinical cases, because we had the data from those locations across the province, what we were able to do is we ended up with the case data, hospitalization data, and we ended up with the wastewater data, all for all the locations. So for that entire population set. And we were then able to say, you could see from prophylaxis when it was administered, you could see that during that point of administration, what were the number of hospitalizations, what were the number of cases prior to that. And what we did is apply just simply, if we would have used, and it was based on a criteria, it wasn't just based upon looking at a curve, there's a criteria applied to the wastewater surveillance data. And once that criteria hit, if we would have applied prophylactic administration at that point, then the model, so we used the RSV model that's been published by Bosco Bass from McMaster University, who's really an amazing RSV clinician and practitioner here in Canada. And we basically just fed that earlier date of prophylactic administration into the model with the data that was already generated at the clinical level. And that basically produced, based upon, data for X number of years, how many cases would have been resolved, how many hospitalizations would have been prevented, how many medically attended visits would have been prevented based upon the precise data sets that were generated during that study. I hope that helped. Sorry if it wasn't detailed enough. Yeah.
No, that helps. And also congrats on your publication being accepted. I have a question for Natalie. So Natalie, you were talking about exploring the use of wastewater surveillance for enteric pathogens. So if local public health were interested in doing this more, what are some pathogens that they should consider? Because there's a lot of different types of foodborne outbreaks that we get, especially during summertime. So what are some things that we could actually take into our decision making to figure out which one is worthwhile to pursue?
Yeah, and I think that one of the things is that we have to remember that just because we can do it doesn't mean necessarily that public health needs that information. There may be robust systems to collect the data, or perhaps there are a lot of gaps, and that's where those gaps are. I hear from public health, norovirus was a bonus, and nobody really thinks about norovirus until you're in the middle of a season like this season, and they really care about it. So I would say, part of it is actually having that like ongoing systematic discussion as to what should be some of those priority pathogens, or other, other targets, including, substances. So I'd say that we have a lot of interest in being able to do monitoring for substances. I know that's outside the scope of this discussion, but that is something that does come up a lot. We are doing some work on looking at enteric bacteria, and this is specifically FoodNet Canada is interested in this data to supplement and complement their enteric bacterial surveillance they're already doing. So we've started to do testing for Salmonella, sugar toxin producing E. coli, as well as Campylobacter. In terms of other pathogens of interest, we have had questions around things like D68. And so to be honest, I would say that almost every time we get a question about wastewater surveillance, it's kind of based on what is in the news and where people want to have more information. So I saw that there was a question there about measles as well. Measles is in the news. It doesn't necessarily mean that it is the best topic, but I do find that it's the best application. But I do find that whatever is the current issue is driving those discussions.
Thank you. I will say your talk about, paying attention to the different strains of norovirus, that's actually something I didn't think about in terms of wastewater surveillance, but I can totally see that being useful. And just to add about your comment about being in the news, something that we're looking to explore in Toronto is potentially using wastewater-based surveillance to help for FIFA. Because we're going to have mass gathering events, and we can do facility-based surveillance for wastewater, and enteric pathogens taken from wastewater at that facility site could really help. So there's always something new and innovative ways that we can look into it. So thank you. And I don't know, do we have time for any more questions, or that's it?
I think we're probably at time, Risha.
Okay.
So I'm going to ask whether Zishan could bring up the evaluation code while I just say a great big thank you to Dr. Natalie Prystajecky, Dr. Rob Delatolla, and Risha Fernandez for the presentations and the Q&A moderation. Fascinating presentations and a great discussion. Please do take some time to complete our short evaluation. It means a lot to us to be able to deliver these webinars in a way that is most valuable to you. You can scan the QR code on this slide to access the survey, or simply click the link in the chat. Also look for the evaluation link in an email that will be shared shortly. Just a couple of key takeaways. What I heard in the discussion is the value of wastewater surveillance may not be to get to the number of cases, that knowing when contagion starts and ends and the trends increasing or decreasing are incredibly important. And the norovirus success story demonstrated how having a signal in wastewater in the absence of clinical detection is important to inform public health messaging. But what I also heard from Rob was it's equally important that you have reliable data and timely data. So we heard his automated system can generate data within 8 hours, whereas some systems for wastewater surveillance can take up to 8 days. So timing is important. So the best examples of wastewater surveillance and the value of wastewater surveillance are those that fill gaps where traditional surveillance methods underperform and that are timely and reliable. I really appreciated Rob's 4 categories: pandemic preparedness, healthcare planning, health equity for equity-seeking groups, including First Nations, and of course, One Health in the face right now of avian flu. So fantastic presentations, fantastic discussion. I do again want to thank Natalie and Rob for sharing their work, and to Risha for moderating, and to everyone who was able to join us for this webinar. The production of the webinar is being made possible through a financial contribution from the Public Health Agency of Canada, and the views expressed do not necessarily represent the views of the agency. Thanks once again to everyone, and I hope you enjoy your afternoon.